esteemed jury, dear participants, listeners, ladies and gentlemen. On behalf of the Student Scientific Association of Medical University of Silesia in Katowice, I would like to thank you for coming and taking part in International Medical Congress of Silesia 2023. My name is Anna Kozub, and together with Karol Krystek, it is our pleasure to coordinate the session of anesthesiology, emergency medicine and intensive care, which is held under the honorary auspices of Polish Society for Emergency Medicine. I would like to cordially welcome the esteemed jury, the president of the jury, Docent Piotr Czempik, and our members of the jury, Dr. Anna Szczepańska and Dr. Jacek Wawrzynek. We would like to explain to you the rules of the session. The order of the presentations will be the same as it is in the abstract book. The maximal time for presentation is 7 minutes and about 3 minutes for the discussion. If the presenter exceeds the time, he or she needs to move on to the conclusions and finish the presentation as soon as possible. You should present your work in English during this session. And during the presentation, the presenter is obliged to share his or her image using a web camera. It is, of course, the rule in case of online participants. And if you are presenting here on site, please stay in front of the camera, just the same place where I am staying just now. Esteemed jury, I would like to kindly remind you that if you are the supervisor of the paper which is presented, you should not assess the work. Other members of the same clinic are able to assess the presentation. The assessment will be then verified. All the presentations and the discussion must be run in English. I would like to remind that if the work is presented in English, the discussion also should be run in English. But if the commission asks the questions in Polish, the authors of the work are obliged to answer in English. If the discussion is run in Polish, the additional points for speaking in English will not be counted in the assessment system. We kindly ask the jury to assess the substantial value, the way of presenting the research, form of discussion, creative own contribution to prepare the scientific work. The evaluation of the works will be held with the usage of electronic system and paper assessment cards. The member of the jury will fill in the form with the usage of prepared device or a paper assessment card, and then the grade will be sent to the server of the organizing committee. As the session coordinators, we mark in the assessment online system whether the presenter respects the time limit of the presentation and the usage of English language. The speakers will be granted additional plus 20% of obtained points for presentation and discussion in English. When the session ends, we kindly ask the jury to assure if all the marks have been saved correctly, in case, of course, of online usage systems, but today we have paper assessment cards, so I think that this will not be the problem. So now I think we can start with the first presentation. So I would like to ask to present the work titled Outcomes of Atrial Fibrillation Treatment in the Emergency Department, 3 years of a Single Center Experience by Hanna Cholerzyńska and Wiktoria Zasada. I think you are online, so you can just share your screen and your web camera.
Okay, can you see me and can you hear me?
Yes, we can, of course.
Okay, give me a second. Okay, can you see my screen now?
Yeah, yes, we can see your screen very well. So when you're ready, just start.
Okay, so hello everybody. My name is Hanna Cholerzyńska and I have a pleasure to present the work of mine and my colleague Wiktoria Zasada with our tutor, Dr. Tomasz Kłosiewicz. And our research was titled Outcomes of Atrial Fibrillation Treatment in the Emergency Department, 3 years of Single Center Experience. Why did we choose this topic? Because atrial fibrillation is the most common cardiac arrhythmia that is a cause of presentation to the emergency department. It accounts for 3.3 to 10% of total emergency department admissions, and it significantly increases geriatric emergency department visits. And as we all know, the elderly population is often the most challenging to care. This is the guidelines, 2020 guidelines for management of atrial fibrillation that we took into consideration during the creation of our research. I put the screenshots here on the screen. They are unfortunately very, very blurry. So we established some baseline of the emergency department treatment of atrial fibrillation. The goal, of course, is to prevent further heart failure development, to lower the risk of strokes, and to get rid of unpleasant symptoms and increase the patient's quality of life. The intervention that physician and the patient can choose, it's either pharmacological or electrical cardioversion or heart rate control. And the choice depends not only on the patient's condition, but also on the staff resources, the organizations and structure in the hospital or the practice, and local practices. So in general, the physician should manage the patient's acute symptoms with, of course, ruling out any underlying dangerous causes. We should also consider introduction of anticoagulation, and we should suggest to the patient that they can follow up in outpatient setting. And finally, according to the literature available, the most recent studies show that it's safe to perform cardioversion in acute atrial fibrillation without further hospitalization, which can drastically decrease the cost of care for this patient, because cost of hospitalizations for the hospital and our healthcare system are much higher than cost of care in the emergency department. So the aim of our study, of course, was to compare different strategies of cardioversion performed in the emergency department and evaluate their impact of length of stay and early complications. Our study was conducted in Poznań City Hospital in Poznań, Poland. We included the patients that presented between April 2019 and March 2022. They were all adults presenting with paroxysmal atrial fibrillation and were treated with an attempt to restore sinus rhythm. We excluded the patients who had spontaneous rhythm conversion during their stay in emergency department, patients taking vitamin K antagonists with non-therapeutic INR, which was checked during the stay, patients taking NOACs not regularly, which was established based on their history, the patient who presented with symptom of shock and that didn't consent to the proposed treatment. We gathered some data from their stay, like demographic indicators, their primary diagnosis, all of the timing, which included the timing of admission, the total length of stay, any drugs used like antiarrhythmics or the procedural sedation analgesia, if the cardioversion was performed, and of course endpoint of the treatment, so if our attempt to restore sinus rhythm was successful or not, and patient's final destination if they were discharged or admitted to the ward further. How did we structure our study? We created 3 groups. Group 1 was treated only with pharmacological cardioversion, so were administered only medications. Group 2 was treated with only electrical cardioversion, so it was shock only. And group 3 was combined, treated first with medication, then with cardioversion. We included 672 patients to our study and then qualified 637 for further analysis. Majority of our patients were triaged yellow, which is here, and orange on the right side of the screen. The most common type of cardioversion was pharmacological only, 62%, and the sinus rhythm was restored in 73% of patients. In case of effectiveness, the most effective type of the treatment was electrical cardioversion only, then combined, and the difference between those two and medications only was statistically significant. In case of length of stay, medications and electrical cardioversion only had similar length of stay, and the combined group stayed for much longer. And here again, the difference was statistically significant between meds and shock only and combined. Complications, the total number was 21 with the rate of 3.2. The most common was bradycardia, then tachycardia and respiratory depression. 14 of the 21 was preceded by medication administration, 4 by the analgesia before shock, and 3 by synchronized shock. If we want to compare our study results to the literature available, the effectiveness of pharmacological cardioversion was in the literature reported between 32 and 90, which was similar to our results, and electrical cardioversion was 94, which is still similar to our. Interestingly, the results of wait-and-see strategy in the literature and early cardioversion were comparable, and the length of stay in our group, the shortest in the electrical cardioversion only, was similar to the majority. However, it contradicted some of them. And conclusions, we established that electric cardioversion is an effective and safe method of the treatment, is associated with shortened length of stay and improved sinus rhythm restoration rate, and complications were due to mainly administration of medications, and were the most common in the groups treated with electrical and pharmacological cardioversion, so they're combined. Thank you.
Thank you very much for presenting the work. Now I'd like to just to ask the jury to ask the questions. So, yeah, okay. So I'm just passing the microphone to the president of jury.
Okay.
Hello, my name is Piotr Czempik. I would like to ask you some questions. Basically, I mean, a nice presentation. It's hard to get all the information in such a short period of time. But I have some questions. I read your abstract before coming here, and I'm not sure if you properly linked the aim of the study with the conclusions. Basically, the title of the paper is Outcomes of Atrial Fibrillation. Outcomes, for me, outcomes are effectiveness of treatment, possibly impact of mode of therapy on length of stay in the emergency department. This for me are outcomes, yes. But you decided in the aim to analyze both length of stay and the safety, the profile of the treatment modalities. These two things are different. So I don't think the title of the work is appropriate here. Maybe the title should be more general, like, for example, management of atrial fibrillation in emergency department, because you analyze lots of information and you aim to evaluate the influence of these treatment modalities on length of stay and their safety. These two things are quite different. And as far as conclusion is concerned, you write that electrical cardioversion is safe and most effective treatment strategy. And then you say that it's associated with shortened length of stay and decreased medical costs. Can you go back, can you turn on your presentation and go back to the times of length of stay in emergency department? Because I spotted that both electrical cardioversion and medical therapy were associated with almost the same length of stay. The conclusion is that it is associated with shortened length of stay. The length of stay was the same for medical therapy and for cardioversion. So I don't think this conclusion is... You see here? So minutes, this was in minutes. So for electrical cardioversion, which you named SH, I don't know why you use this abbreviation. Does it stand for anything?
It's a shock only.
Okay, it stands for shock. Okay, shock.
Yeah, I had it in
because I wasn't a shock only.
Oh, it's here.
Okay, shock only. It's for shock. Okay, so in shock group, the length of stay was 180 minutes, and for medical therapy it was 181 minutes. Yes, so the difference wasn't significant. And the conclusion is it's associated with shortened length of stay. The same thing you could say that both medical and shock groups had shortened length of stay compared to combined. Yes. Yeah. So this conclusion is ungranted. Yes. And then in conclusion, you say that it's associated with decreased medical costs. Have you performed the proper economic analysis? Because, you know, electrical cardioversion doesn't have to be the cheapest option, because you have to calculate lots of things. Yeah, work of the anesthesiologists. I don't know who was anesthetizing these patients for electrical cardioversion.
Emergency department physicians.
Emergency department physicians. Okay. And another thing is that can you go back to the effectiveness? No, sorry, to safety profile. That there was something in the presentation I was aware that almost the last slide.
Yeah.
Okay, so the total number of complications is 21. Complication rate in general was 3.3, and there were 14 incidents in medical group, 4 in procedural sedation, and 4 by procedural sedation and 3 by synchronized shock. Can you explain? Can you elaborate on the safety? Can you explain to us? Because this is not like there was different number of patients in these groups. Yes. Can you tell me the percentage of complications in all 3 groups? Because the numbers were different.
Yeah, I don't have it here, so I probably would need to go to my paper and like check the numbers or count it on my phone right now. Do you want me to do it?
No. I don't want you to do it now, but this is something I think you should focus on. I don't know. Yeah, I mean, lots of suggestions from my side, but definitely important topic
thank you.
For emergency physicians. Last thing is that these patients that attend emergency department, they are usually not fasted, yes? And do you know how many patients were decided not be cardioverted because of being not fasted? Yes. Do you have this information? Because it's important. Yeah. I imagine that patients attending emergency department are not fasted mostly, and in order to perform safely sedation, procedural sedation, they should be fasted. Otherwise, you risk aspiration.
Yeah,
this is something that you should think of as well. Okay.
Yeah.
Okay. Sorry, lots of suggestions. Have you any other comments?
Is that the question for me or to your colleagues?
That was very nice presentation. My question is about the qualification criteria, because the success with the shock is determined by the size of the atrium and electrolytes balance. Was it tested before? Did the patient echo performed or not?
I don't think they did. And to my knowledge, I don't think they did.
How about the potassium level? Was it checked before or not?
Yeah, of course. All the laboratory panel was did in all of the patients, so all the electrolytes and the glucose levels and the basic laboratory results were checked, of course.
Okay, and next, my question is about the length of stay. What's your personal opinion? Why the stay was longer in a group of patients that the treatment was combined? What's your opinion?
I think because first they were tried with medications and then with shock. So like the two treatment modalities were included in this group. So I think first the failure of first treatment then led to the second treatment. And I think the two treatments combined were, that's why they stayed longer. And the group with medications and shock had only one treatment. So yeah, that's why I think.
Thank you very much for the discussion. And now we would like to move on to the second paper named Polish Perspective on E-scooter-related Injuries, a 3-year observational study into emergency centers by Wiktoria Zasada and Hanna Cholerzyńska. I think that, that's the paper which will be presented online. So when you are ready, just start presenting.
Okay, I need a minute for the presentation.
Just say when you will be ready.
Okay. Yeah, is it visible right now?
Yes, it's visible and you're audible, so you can start.
Okay, great. So once again, good morning, everybody. Thanks for joining me today. My name is Wiktoria Zasada, and I will be presenting a 3-year observational study on e-scooter-related injuries. So maybe let's dive into more details. This is our graphical abstract, but maybe we can look at it later. So electric scooters, also known as e-scooters, have become increasingly popular as a sustainable and cost-effective mode of transportation in urban areas worldwide. And the COVID-19 pandemic has further highlighted the importance of individual transport options, as we all know. So more and more people switched from public transport to single-person modes. Studies have shown a significant rise in hospitalization due to e-scooter-related injuries. As the popularity of e-scooters has grown, so have the numbers of accidents and emergency department visits. These alarming trends, we think, necessitates a closer examination of the epidemiology and characteristics of those injuries in order to develop effective preventive measures. Okay. So however, as we established, despite the growing number of those injuries, there is limited information available of the specific nature of those outcomes and their impact on emergency departments, especially in Poland. So our study aims to bridge the gap and provide valuable insights into the prevalence, the patterns and outcomes of the e-scooter-related injuries in our country. Okay, a bit about our methods. The study was conducted in 2 emergency departments in Poznań and in Bydgoszcz in Poland. We retrospectively analyzed the identified data from e-scooter-related visits between March 1st, 2020 and March 1st, 2023, covering a span of 3 full years. The inclusion criteria were age over 18 or older and confirmed e-scooter use related injury or injuries. Here's some relevant data, patient demographics, injury characteristics, and medical procedures that we extracted from the hospital's software. Here's some more details about it. During the study period, 414 patients presented to the both emergency departments with injuries associated with e-scooter use. The majority of patients were male with a median age of 27. The median length of stay was 95 minutes, and surprisingly, alcohol consumption was confirmed only in 2.9% of cases. Most admissions occurred in the afternoon and at night, as we see on the graphs, and weekends and the summer season had the highest number of accidents. Falls were the most common mechanism of injury, 73.9%, and the heads and the extremities were the most common sites of injury, with the contusions being the most prevalent type. Okay. The admission rate was 13.5. Most of the patients could be discharged home. Okay. Yeah, about the study, it provides the first comprehensive analysis of e-scooter-related injuries in Poland over the period of the 3 years. So in comparison to the available literature, the demographic profile of our patients aligns with prior studies with a predominance of young adults. However, the median age in our study was lower than previous investigations. Helmet usage was minimal, indicated the need of stricter regulations, definitely. Surprisingly, alcohol consumption was low compared to other studies, and falls were the most common mechanism of injury, highlighting the needs for improved safety measures. In conclusion, the increasing popularity of e-scooters requires appropriate regulations to ensure safe usage. The injuries can significantly impact young adults' daily activities, particularly when head and extremities injuries occur. Therefore, local governments, we suggest, should prioritize more strict regulations, invest in infrastructure, and promote education on safe e-scooter use to minimize the risk associated with this mode of transportation. Yeah, here we came back to the graphical abstracts to summarize some of the key points, but I didn't start my timer, so maybe I'll go on. Okay. So here are the references, and thank you for the attention. Maybe I would like to acknowledge the support from our university and the participating emergency departments. So now I'm open to any questions or discussions that you may have.
Thank you very much for your work. So now I'd like to invite you all to ask the questions and discuss the presented paper.
Do you know, good morning, my name is Jacek Wawrzynek. I'm a chief of Emergency Medical Service Department in our university. Do you know how many patients were transported by ambulances?
No, I don't think we have a look. Yeah, we looked at it, but yeah, that's a good question. Mm-hmm. I think we should
I don't have good experience in this type of patient, but unfortunately, I think that brain injuries are the most popular in this group. You show that this is not a big group in your study, so this is. I don't have any questions.
Okay.
So maybe I will share my ideas. That was nice presentation. Hello, my name is Anna Szczepańska. Would you consider the transfer with the scooter as a dangerous thing, that we should rather use something else, and is, well, initially seems to be quite cheap way of transfer, but when you can calculate all those things you've mentioned, can be quite expensive. My question was about the period. As you mentioned, it was the pandemic time, so that could also decrease a little bit of amount of cases. Next question is, should we consider helmet as an obligatory thing that should be used for this way of transfer? And it was just one city. It was just in Bydgoszcz.
In Poznań to
Poznań. Mm-hmm. So maybe we should consider including more cities to your study to have.
Yeah, definitely. It would be great if we can include more data, but the logistics of that are kind of complicated. But maybe we'll try it in the future. Yeah, I think in Poland, I think if you ride a bike, it's not obligatory to have a helmet, right? If I'm not wrong. So probably it would be hard unless you're a child to enforce these policies right now, but maybe in the future. Yeah.
Thank you.
Thank you.
My name is Peter Czempik. I would like to ask you a question on the number of these visits. What was the percentage of these visits in the total number of PD visits? Because you said, because this is important. Is this? I mean, we know that there were 414 patients. I don't know about the how many visits you have in these two hospitals. Can you comment on that, please?
Yeah, I think we have this data. I didn't include it in the presentation, but we want to include it like in the paper if we get to publish this. But yeah, that's a good question. I don't have the numbers with me.
Roughly,
so.
Do you know roughly what was the percentage?
It's a small percentage. It's a
small percentage. Okay, because like in the background, as a background, as an introduction, there was a statement that the number of these injuries is increasing because the use of these e-scooters is increasing. That's why I just wanted to know if this is a significant number of injuries that have to be managed in ED.
Like in total of the all injuries.
Percentage. What's the percentage? Yeah, that's why I'm asking the question.
Yeah, great question. We probably will answer it in the publication if we get to this. Yeah, but thank you.
Okay, and can you go back to the aim of the study with your presentation? Because it's important, to answer the question that you aimed for. Yes, because you always aim for something. So yeah, this is not the aim of the study, isn't it? This is the background.
Yeah, like I think it's kind of spread it over those 3 slides and like included in the background, because we state that there is we see the increase of the injuries, and we want to investigate the outcomes and the characteristics and epidemiology of those injuries to help develop the preventive measures or suggested.
Okay, so you wanted to know the epidemiology and the clinical characteristics of these injuries. This is okay, but conclusions. In conclusions, I see lots of discussion topics. Like conclusions is not discussion.
Okay.
Just a point to you to improve your presentations. Lots of discussion in the conclusions.
Yeah. Okay.
The conclusions are based on the results. Yes. There might be some suggestions in the conclusions, but not like part of the discussion.
Okay.
Conclusion is conclusion. It should be short, and I also advise you to have shorter titles when you will be publishing. Yeah, when you will be trying to publish, keep the titles short. Because they don't sell well.
Okay, to be more engaging.
Okay, thank you.
Yeah, okay, great. Thank you for the feedback.
Thank you very much for your comments, for all the remarks. And now we would like to move on to the third presentation. To the predictive role of blood gas fluctuate in emergency department in
So good morning, everybody. My name is Szymon Gawenda, and I'm going to present the results of our work entitled The Predictive Role of Blood Gas Lactate in Emergency Department in Patients with Severe Dyspnea. Before going on, I would like to remind that lactates are the end products of glucose anaerobic metabolism, but sometimes, especially in inflammation, it can be produced in aerobic conditions. And hyperlactatemia is considered a hallmark of organ perfusion impairment. Okay, so let's start. And here you can see the standard triage procedure that is used in many hospitals in Poland, included one that we made our research in. It's based on taking medical history, examining the patient, as well as doing these 3 tests. And that looks quite simple, right? But dyspnea isn't simple. It's the symptom that occurs in many various diseases. And as you know, it's a subjective feeling, which makes it even harder to reliably assess. And at the same time, it's one of the most common complaint on admission to the emergency department. And knowing that, we asked ourselves a question: is there a parameter that can help physicians assess prognosis in patients with dyspnea? So we conducted a retrospective study in which we focused on blood gas analysis. When it comes to materials and methods, we obtained data from medical files of patients admitted to the emergency department from 3 months. And to our research, we included patients with dyspnea or patients at risk of respiratory failure. And these were patients with infectious pulmonary diseases, other pulmonary diseases, mainly asthma and COPD, patients with heart failure, but we excluded those with myocardial infarction and arrhythmias, and finally, patients with neurological disorders. From these groups, we selected those in which doctors, based on patients' clinical image, decided to do blood gas tests, which finally left us with 108 patients with blood gas tests, and then we were checking if they have died or survived. Now I would like you to look at this table when you can see that the majority of patients who died were women. The median age was nearly 80 years old, and the most common reason of admission in these patients was heart failure. As you can see, those patients had significantly lower blood pressure, mean arterial pressure, and oxygen saturation. And they most often have some kind of oxygen therapy on the emergency department, usually a face mask. And moving on to the main results, we divided our population into 3 subgroups. As you can see, it's arterial, venous, and mixed blood gas group, which consisted of both previous ones and additionally those patients in which we couldn't assess the FeO2 parameter. Here you can see that the overall mortality was 35%, and it was higher in arterial blood gas group and lower in venous blood gas group. Okay, and now let's focus on arterial blood gas results. As you can see in the second line, there is a statistically significant difference between lactate concentration in those patients who died and those who survived. And it is higher in those who died. What's interesting, bicarbonates are significantly lower in patients who died, which correlates with lower value of GFR in those patients. And since the differences between groups in partial pressures of oxygen and carbon dioxide aren't significant, we can assume that the reason of these changes is impaired tissue perfusion, as well as indicators of chronic kidney disease, which occurs significantly more often among patients who died. Here we can see the results for arterial blood gas group. The cutoff for lactate was 1.5 millimoles per liter with area under the curve 0.81. And we observed a similar tendency in a mixed group with cutoff for lactate 2.5 millimoles per liter with area under the curve 0.74. And finally, the venous blood gas. Also here, the p-value for lactate concentration is lower than 0.05. But however, here we do not observe this tendency for bicarbonates, mainly because doctors ordered venous blood gas test in patients in overall better condition, which correlates with a lower percentage of mortality in this group. Okay, so what are the conclusions from this study? First of all, blood gas testing, because it's very quick and simple, should be considered as a standard triage procedure on the emergency department, especially in dyspneic patients. Second, and I think the most important, blood gas lactate have a predictive value in patients at risk of respiratory failure. And moreover, this statement is true not only for arterial blood gas, but also for venous blood gas, which is much easier to obtain. And third, the last one, we should remember that blood gas is a very useful tool, which can give us a lot of information about our patient in just a couple of minutes. And it's not reserved only for patients in severe condition or those in intensive care units. Here are sources that I used preparing this presentation. And thank you for your attention. If you have any questions, I will be glad to answer them. Thank you.
Thank you very much for your work. Please stay here and I'll just pass the microphone to the jury.
I've got two really short questions. First, where is this emergency department? Because you don't tell us in which city.
This is the emergency department in Katowice, Ohio.
Okay, great. And the second, what is your opinion? Do you think that the possibility to measure lactate in pre-hospital care is important? For example, in ambulance?
To be honest, for me, the most important conclusion that is from this study is to do blood gas tests more often, also in pre-hospital condition, and to focus not only on pH, PO2, and PCO2, which is, of course, the most important factors of these blood gas test results, but also look at lactate concentration and think of it, what it says me about my patient.
Okay, so it could be useful for us.
Yes, I hope so, yes.
Thank you.
That was very nice presentation again. My question is, because this dyspnea group is very heterogeneous group, so it's quite difficult to run the conclusions from such a heterogeneous group, because anaerobic metabolism is, such different for different patients. You've got patients with underlying diseases like liver disease, so it's quite difficult. And my next question is, was it only arterial blood gases, or was venous blood gases results included in your analysis also?
Okay, so let me answer the first question first. Yes, it is heterogeneous group for sure, but we measure that the lactate can have predictive value in those patients, and of course lactate can be higher in multiple diseases, not only with hypoxia and hypoxemia, but also with liver impaired when the clearance of lactate is not sure. And we connected all these dyspneic patients together, and our result is that lactate have a predictive value. But we do not focus on each reason of this dyspnea. And the second, yes, we have another group for arterial blood gas and another for venous blood gas.
Thank you.
So thank you very much for your work. And now we will move on to the next presentation called What Blood Pressure and Vasoactive Agents Tell Us About Capillary Refill Time, a Prospective Analysis by Fabian Wesołek, Robert Latacz, and Wiktoria Staniszewska.
Good morning. My name is Fabian Wesołek, and today I want to present you the results of the work we've been doing for the last 6 months. What blood pressure and vasoactive agents tell us about capillary refill time, a prospective analysis. Can I have a pilot? Okay, so a common hemodynamic approach in managing critically ill patients is to attain mean arterial pressure above 65 millimeters of mercury, and it is based on the guidelines from Surviving Sepsis Campaign from 2021. It is also made on the assumption that such pressure should sustain blood flow to vital organs. But 79% of septic shock patients have MAP attained within the first 3 hours of septic shock resuscitation, and 40% of these patients die. How so? Blood pressure does not equal organ perfusion? Then what reflects perfusion? And as you can see on this graph, there is a distinction between macro and microcirculation, what suggests that despite normal mean arterial pressure, the microcirculatory dysfunction can still persist. Capillary refill time is a simple, accessible, and easy to perform test, and it is a marker of capillary skin blood flow, which is mostly based on sympathetic stimulation. In 2019, a clinical randomized trial was performed. It was called Andromeda shock. And the researchers proved that an altered CRT is associated with worse outcome and with organ perfusion derangements. What is more, they compared resuscitation targeted at normalizing CRT. And it turns out that CRT is a good target in resuscitation, and it has been associated with less organ derangements and an increased survival in septic shock. But what are the factors that affect CRT? There is cardiac output, there is vascular resistance, and there is mean arterial pressure. And despite many works on this topic, there is still little known about the relationship between these variables. And here we are with our study. The aim of our study was to assess if in stable, critically ill patients, is there a relationship between MAP and CRT, and whether the dose of vasoactive agents affect CRT. This was a prospective observational study, which was registered in clinical trial. It was conducted in tertiary hospital in the intensive care unit, and we included stabilized, critically ill, ventilated, and undergoing vasopressor support patients with arterial catheter. CRT, MAP, and vasopressor doses were measured simultaneously and analyzed by using Spearman's rank correlation. To measure the CRT, we used a standardized technique to guarantee a good inter-rater reliability. We applied the pressure for 10 seconds, and to standardize it, we took a lab slide. To standardize the light, we used an iPhone flashlight, and to standardize the duration measurement, we used a chronometer. And all the factors applied are shown on this video. Going into results of our study, 165 MAP CRT records were prospectively acquired from 61 patients during the course of the ICU hospitalization. The median CRT was around 2 seconds, and the median MAP was around 81 millimeters of mercury. The ICU mortality was 26. Going into the first aim of our study, we found no correlation between MAP and CRT. As you can see, the correlation line is almost horizontal, and there is a wide dispersion of CRT values for each of the MAP level. We also made a scatter plot for CRT values for patients with MAP below 65 millimeters of mercury. And there were 13 cases of MAP below 65 millimeters of mercury, and only in 2 of these cases, the patients had an altered CRT, which suggests that hypotension generally did not translate into worsened skin perfusion. So there was no shock, and the patients weren't centralized. Going into the second aim of our study, there is a positive but low significant relationship between vasopressor doses and CRT values. So the higher norepinephrine equivalent, the more prolonged CRT is. I would also like to point out one detail. There was no correlation between CRT and lactate values, which again proved that lactate may not be a good indicator of perfusion problems. Going into conclusions. In critically ill patients undergoing vasopressor support, CRT values could not be explained by MAP. And there is a signal indicating the effect of increasing doses of vasopressive drugs on CRT values. What is more, the assessment of peripheral perfusion carries an independent risk information regarding the hemodynamic status. I would also like to say that I think our work is a reminder that despite all of the modern technology we have, the physical examination is still a gold standard in monitoring critically ill patients, and that sometimes simple strategies can solve huge problems. Thank you very much. And I invite you to a discussion.
Thank you very much for your work. Please stay here, and I will just pass the microphone to our jury members.
My first question is, did you expect the first conclusion? The first conclusion is that the CRT is not correlated with MAP. Did you expect that? Because, you know, like the literature, we already know that the micro parameters and micro parameters, they don't correlate. Did you expect that there is no correlation, or did you expect that there will be correlation? What were your expectations on this point?
I don't think we expected the correlation.
So you expected that there will be no correlation? Okay. Did you expect that there would be no correlation between lactate and CRT? Did you think that by doing this, you will see that increasing lactate correlates with increased CRT? Okay, because it's again lactates. This is parameter that we use because this is the parameter that is widely available. But yet again, in patients, especially in septic patients, there are so many other causes of increased lactate that for example, when I personally treat a patient, for example, lactate, okay, I look at the lactate concentration, but then I realize that there are so many factors that affect the lactate concentration. Yes. So for me personally, lactate is not a hemodynamic goal all the time, like every time. Yes. But definitely CRT is something that I will look at. And it's important. I think it's easy to perform, as Andromeda showed already. You can do it multiple times, every 15 minutes, etc. What's really interesting that it's can you go back a little bit with the presentation? There is the information that only two about the CRT and that only two patients the CRT like in patients with MAP below 65. Only two of these patients who had MAP below 65, the CRT was altered, was prolonged. This is interesting because this shows that again, like our goal, our macro hemodynamic goal, which is 65 millimeters of mercury, doesn't correspond. Shouldn't be like this is like arbitrary level that comes from previous research, but it's probably there will be some patients that will do well with MAP lower than 65. This is interesting, but yet again, yeah, MAP and microcirculation, like microcirculation and my macro and microcirculation, that they don't come along, yeah. But this is something that I find interesting. So more like comments from my side than some remarks regarding the design and the performance of the study, which I really like. Thank you very much.
I find your results as extremely interesting, and my opinion is that we should really aiming this way. My question is again, do you think that MIAP should be kind of personalized, that we should instead of tracing numbers according to the guidelines, choose the personal number of MAP for the patient we deal with?
Yes, totally. Because as our study, as this slide show, you can't just base on some guidelines, and you need to have some wider look at your patients.
And my next question is, any other clinical assessment comes to your mind that could be as useful as CRT when we are dealing with a patient in shock? Like, I don't know, pulse checking or auscultation or something else.
I think during our work, we didn't explore any other. We just focus on CRT and how cheap and easy accessible it is. And that's what we wanted to show today.
Okay, thank you very much. Very nice presentation.
Thank you very much.
Thank you very much for your work, for all of the questions asked during the discussion. And now I'd like to move on to our next presentation called Assessment of Fluid Volume and Sodium Count in ICU Patients with Sepsis, Single Center Retrospective Study by Jakub Rudzki and Dominika Kazimierczak.
Dear jury, ladies and gentlemen, I'm honored to present you our research about the assessment of fluid volume and sodium count in sepsis patients during ICU stay. So sepsis poses a significant challenge in ICUs, and while the resuscitation fluids remain our primary focus, it is crucial to consider other fluid sources because they can constitute a significant fluid volume administered to septic patients. So now let's discuss the effects of sodium and fluid overload. So as you know, the sodium and fluid overload can cause the fluid retention in patients, which then may lead to interstitial edema, impairment of microcirculation, impairment of tissue oxygenation, which leads finally to the organ dysfunction. And on the other hand, hypoperfusion does the same thing. It impairs the microcirculation in tissues and leads to impaired oxygenation, which then leads to organ dysfunction. And both of these things leads to adverse outcome. So it's very important to maintain a responsible fluid therapy in septic patients. So we aimed to assess the fluid volume in sepsis patients. During ICU stay, determine proportions of resuscitation and non-resuscitation fluids in total fluid administration, and evaluate sodium burden in sepsis patients. So we conducted a retrospective analysis of medical documentation in our department from December 2021 to December 2022, and we recruited first 29 patients with sepsis in ICU from the studied period after applying the inclusion criteria, which was the sepsis-free protocol, and exclusion criteria, continuous replacement renal therapy, and abdominal sepsis. Now moving on to the results section. So as you can see, the main infection sources were pneumonia in 17 cases, urinary tract infections in 11 cases. The cumulative ICU stay was 367 days, and the ICU stay per person was median 8 days. We also evaluated the SAPS-2, APASH-2, and SOFA scales to assess the severity of the sepsis in our group. As you can see, a total of 956.4 liters of fluids in the whole group was administered, and a total administered fluids per stay were was median 16.8 liters, and the median fluids per day per person was 2.6 liters. So the resuscitation fluids, which we can be worried about and concerned about, were presented a median volume of 1.9 liters, which is not that much. And for the purpose of this study, because it was a retrospective study, we counted resuscitation fluids as all fluids administered on the admission day. So the total volume of intravenous fluids per person per stay was median 11.1 liters, and a total volume of enteral fluids per person per stay was median 7 liters. And now here is a more detailed version of the fluid sources, and you can see the big disproportion between the resuscitation fluids and intravenous drugs, which played a role in almost 60% of fluid volume administration, whereas the resuscitation fluids play a role only in 10% of fluid sources. So now let's move to the sodium burden in our group. So a median sodium count per stay were 42 grams median, and daily sodium count per person was median 5.1 grams. And here I put a small frame to indicate that this amount exceeds the norms of sodium dosage per day. So then you can see the sodium load from resuscitation fluids per person was median 7.3 grams. And now you can see another disproportion because the IV drugs accounted for over 30 grams of sodium load median per stay. And now the more detailed version, and you can see the same disproportion as before because the intravenous drugs were responsible for 70% of sodium load, and resuscitation fluids were responsible for 15% of sodium load. And you can see I also marked the drugs in saline because they contributed 22 grams of sodium median per one stay, which is a substantial amount. So now coming up to the conclusions. Intravenous fluids accounted for the biggest sodium burden and volume of all administered fluids. Non-resuscitation fluids compared to resuscitation fluids played substantial role both in fluid volume and sodium burden, and daily sodium count in septic patients in our group exceeds the WHO daily sodium intake recommendations. So we should think about changing drug solvents when it's possible to possibly avoid those adverse effects. And not every drug requires a saline as a solvent. Thank you very much. Does anyone have any questions?
Thank you very much for presenting your work. And now I'd like to ask the jury whether they have any questions or other remarks to the presentation.
So ideally it's about the dissolving of drugs that we prepare for the patient, yes? So it's quite difficult because this is about the characteristic of the product, how we should dissolve it, and if the producer tells that we should dissolve it in like 100 mils of normal saline, then it's difficult to change all the time this prescription. Sometimes we do change this prescription into water, into aqua, but normally we should rather avoid that because this is in contradiction with the prescription of the drug. But that's good conclusion that we should rather aim at least reduce of the volume of the solvent. Thank you.
Thank you.
Well, this was done in our department, and we have our thinking about the solvents. It's that we prefer, if possible, we use this distilled water as a solvent for medications. And this is information that even if we try to reduce the amount of sodium that we give to our patient, we still are above the recommended doses. I don't think, we can't do much about that, but because like my colleague said, there are certain characteristics. There are certain drugs that can be dissolved in different fluids, but there are some that have to be dissolved in sodium chloride. This is not only our problem here in our department. Yes, you showed the amount is huge of this intravenous, like I would call it not intravenous fluids, only like maybe dissolvents. How do you say it? Because I got confused somewhere during the presentation, which is the intravenous, like what fluids are dissolvents and which fluids are like medications that we give. I got confused a little bit. This is something just to change the wording of the English wording of that. And well, you showed that the dissolvents, they play a major role as an amount of fluid and amount of sodium, but of course we have in terms of volume load, we have control on that because you said that the amount of fluids given. Of course, we keep the patients. We try to keep this patient euvolemic. Yeah, we don't allow patient to go hypervolemic because it's as you know, this is the predictor of mortality. I don't know. Well, nice work. You answered the aims in conclusions. I think that this is the right. Can you go back to the last slide sure. With conclusions? Yep. Think about changing drug solvents. I think we mostly already done that in our department, and still this is a problem. But that's just my opinion because I know the department. Thank you.
Thank you very much. Any more questions?
Last conclusion that I'm quite surprised that our resuscitation volume is not that large as I thought. Thank you.
Fine. Thank you.
Thank you very much for the discussion, for presenting your work as well. So now we would like to invite to us the next interlocutor with the work Pulmonary Hypertension Modifies Course of Hospitalization of Critically Ill Patients with COPD Exacerbation by Jan Herzyk, Mateusz Gołdyn, and Dawid Wilczek.
Good morning, everyone. My name is Mateusz Gołdyn, and me with my colleagues Jan Herzyk and Dawid Wilczek conduct study. The exact title is the Pulmonary Hypertension Modifies Course of Hospitalization of Critically Ill Patients with a COPD Exacerbation. Can I file it, please? Thank you. It's right here. So the exacerbation of the chronic obstructive pulmonary disease is one of the most common cause of admission to the ICU. And the severe COPD actually may leads to pulmonary hypertension and requires mechanical invasive ventilation. And the symptoms of the COPD pulmonary hypertension may be reduced or can be reduced by enterally administered sildenafil. No, it's not working. So the aim of our study was first to characterize patients with exacerbated COPD requiring invasive mechanical ventilation, focusing on the dynamics of respiratory and metabolic compensation. And the second, to assess potential outcome differentiation between patients with or without the addition of sildenafil in the treatment protocol. Thank you. Our study was retrospective. We include 107 patients. All of them were diagnosed with the COPD. They requiring invasive mechanical ventilation. They were hospitalized in intensive care unit here in clinical hospital in Katowice. They were hospitalized from January 2018 to July 2022. The pulmonary hypertension features were assessed using the echocardiographic examination and measurements like the LV to RV, basal diameter ratio, TAPSE, the IVC diameter, the IVC collapsibility. And the data we analyzed were arterial blood gases tests, complete blood count, the need of intubation, the duration of mechanical ventilation, and the respiratory compensation, and of course, the ICU stay and ICU mortality as the ICU stay outcome. This is the flowchart of our study. As I said, we include 107 patients. 60 of them were treated, were receiving additional sildenafil in the treatment protocol. We analyzed our data using descriptive statistics, both group comparisons and correlation coefficients. The median total dose of sildenafil administered through the ICU stay was 675 milligrams. Sildenafil treatment most frequently started on the second day after ICU admission, and the median sildenafil administration period was 7 days. That chart actually represented whole group. The duration of mechanical ventilation was median. Duration of mechanical ventilation was 120 hours. Patients receiving sildenafil tended toward longer mechanical ventilation, longer duration. borderline significance, although borderline significance. The PaCO2 correlated with the mean ABG hydrogen carbonate concentration would actually reflect the metabolic compensation mechanism with the stronger correlation in the group of sildenafil, subgroup of sildenafil treatment. About the pH compensation, the pH compensation differed between deceased patient and the survivors with the statistically significant result. Also, the mean PaCO2, where the mean PCA, the patients receiving sildenafil had a lower mean PCO2 with the statistically significant result, and higher mean PaO2 with a statistically significant result. The patient receiving sildenafil treatment also had a lower mean hematocrit, although borderline significance. And the last one, deceased patients had a lower mean hematocrit comparison to the survivors one. So what was it all for? Sildenafil may have affordable effects on gas exchange and ABG compensation in patients with the COPD, pulmonary hypertension. Sildenafil should be considered in all critically ill patients requiring mechanical ventilation due to exacerbation of chronic respiratory disease. And the third one, frequently echocardiographic examination may identify patients with the clinical signs of pulmonary hypertension and potentially responsive to the treatment with the sildenafil. Thank you very much for your attention. I'm so glad to be here and waiting for your questions.
So thank you very much for presenting your work. And now I think it's time to start our discussion.
Thank you for your presentation, guys. How did you assess your pulmonary hypertensive patients? I mean, when did you, I could note that you tried to measure the ventricle size, you've tried to measure TAPS and intravenous inferior vena cava size, but these are not the parameters for the pulmonary hypertension assessment at all, I'm afraid.
That actually was a retrospective study. So we base on this data. Of course, the basal diameter is not a sign of pulmonary hypertension, and it may be an indicator that something goes wrong. The European Cardiology Society recommends these methods as something like method to measure that something's gone wrong and with the heart and with the pulmonary circulation. But of course, it's not a 100% method that can tell us that the patient have the pulmonary hypertension.
I can't agree also with the second conclusion that you should consider sildenafil for whole patients that needs the ventilation due to COPD reasons. It's not only about the COPD, usually the ventilation that need. So I can't agree with that conclusion. And so you have actually you've been reading our description of whole patient, and then you've been assessing them as a pulmonary hypertensive patients, yes?
Yes, of course.
Correct. Okay.
They may have a pulmonary hypertension, and then the sildenafil treatment was included, the treatment protocol. And of course, not every patient should be on the sildenafil treatment, yes, of course, but our study showed that patients requiring mechanical ventilation may have a better metabolic compensation during the hospitalization when the sildenafil is included in the treatment protocol. That's the idea.
Okay. We shall discuss it later on.
Okay. With pleasure.
Thank you very much.
Thank you very much.
Thank you very much.
And now it's time to move on to the next presentation called Is My Patient Asleep? Assessment of the depth of anesthesia using the measurement of the preceded EEG signal by Julia Lipina, Aleksandra Boral, Zofia Kosztyła, and Adrian Bobrzyk. Micro. Now.
Good morning, ladies and gentlemen. My name is Julia Lipina, and today I've been honored with the possibility to present to you our project called Is My Patient Asleep?, focusing on assessing depth of anesthesia in pediatric patients. So, as far as we're concerned, depth of anesthesia is a critical factor when it comes to both patients' safety and comfort while undergoing a procedure. Commonly used methods can be called subjective, which allows us only for a subjective assessment of depth of anesthesia. And however, inadequate depth of anesthesia might lead to pain and discomfort as the most common complication, really serious post-operative complications like delirium, and even long-term complications such as post-traumatic stress disorder, especially when it comes to pediatric younger patients. So we can assess depth of anesthesia in an objective way using the transformed EEG signal method. We use a device called Triton, which can help us obtain numerical value that would indicate depth of sedation. Desired values are in range between 40 and 60. Anything below 40 means that patient was sedated too deeply, and anything over 60 might mean that our patient is not properly anesthetized. And while patient is undergoing the procedure, the commonly used method of assessing anesthesia during complex general anesthesia is monitoring minimal alveolar concentration value, hemodynamical parameters of our patient, and observing patient. And processed EEG signal assessment is recommended method in IV anesthesia. However, the aim of our study was assessing depth of anesthesia in pediatric patients using the processed EEG signal methods and finding out how certain factors occurring while patient is anesthetized might affect how deeply he is anesthetized. So as for materials and methods, we've conducted our cross-sectional study in Upper Silesian Children's Health Center in Katowice, Poland. We've included patients over 8 and under 18 years of age, anesthetized for elective procedures in a period between February and March 2023. Measurements, as I mentioned before, were took with Triton device at fixed hours, once for every given patient. And for exclusion criteria, there was no inhalation anesthesia, age below 8 years old, and ASA value 4 or over that. As for the results, for the general statistic, we included total number of patients being 17, 31 being female and 39 being male. Mean age was 20.7 with standard deviation of 3.3, mean minimal alveolar concentration value being 0.8 with standard deviation of 0.2, mean Triton value being 50.1, so exactly in the middle of desired values with standard deviation of 5.6, also within desired values, and mean time from induction 29.5 minutes with standard deviation of 26.8 minutes. As for group differences, we've noticed that when it came to AHP values stood at 0.9, and there were no significant differences when it came to age and depth of anesthesia. And same thing applies for minimal alveolar concentration value with P standing at 0.18. And as we can see here, both MAC value and Triton value were in the desired range, meaning that all patients were anesthetized properly, except for a few outliers, but they were also within the ranges that we consider proper. When it comes to the dependence and time, we've noticed no any clinically significant correlation when it came to minutes from induction, as the p-value stood at 0.97. As for the moment of procedure, as you can see, some patients were measured before the surgery started, some during the surgery, and some right after the surgery, just before waking them up. There were also no any significant correlation for us. And as for anesthesiologist experience, even though there was no any clinically significant correlation, we've noticed that younger and less experienced anesthesiologists, like residents, they tend to anesthetize patients a little bit more deeply. And the older specialists with more experience, they tended to anesthetize patients in a lighter manner. So as for the conclusions, clinical assessment using the treated and processed EEG signal methods was consistent with measurements of hemodynamical parameters, MAC value, and as well as observing the patients. And all patients from investigated groups were anesthetized properly within desired values. Thank you everyone for your attention. And now I'll be pleased to answer any questions and participate in discussion.
Thank you very much for your work. Now it's time to begin the discussion.
First, a little bit concerning this MAC of 0.8. Can you comment on that? Because as you know, we should keep the MAC at 1 at all times to prevent the intraoperative return of consciousness, yes? Do you know why the MAC was 0.8 in the study, in this group of patients?
I think that comes from a lot of patients being measured right after intubation and anesthesia, as well as a kind of bigger group was measured during waking patient up, so just right before intubation. That's why the minimal overall concentration went down a little bit. However, we are concerned that we're certain that patients were anesthetized properly due to anesthesiologists didn't know the MAC, the treatment value, and they were anesthetizing patients based on, as I said, hemodynamical parameters and MAC value, and they were certain that patient is in a proper state.
Okay. The conclusions that you put there is, can you go back to conclusion? The clinical assessment of adequacy of depth of anesthesia based on MAC. A MAC is not clinical assessment. MAC is instrumental assessment of depth of anesthesia. So like the wording is, I don't like the wording here. So and as far as factors that have effect on the depth of anesthesia, you couldn't find any that changed, that have impact on it. Do I have it right?
Yes, but we have to acknowledge our study limitation, like not really big of a group that we've assessed. However, as for our observation, we've noticed that the most important factor is a human factor, being anesthesiologist experience, personal preparations when it came to gas and doses of administered medicines, as well as just frame of mind on a given day, because we've had like a group of anesthesiologists from Upper Silesian Children's Center, and same anesthesiologist on one day, they anesthetized in a lighter manner, on the other day on a heavier manner. So we think that even though it's not really shown in the results.
Yes, but it's not about heavier, lighter. The adequacy has to be proper, and how to judge, how would you decide which patients anesthetize lighter or heavier? This is it's not about lighter and heavier, it's about the right level of anesthesia.
Yes,
I don't know if you know.
I maybe used a little bit of incorrect wording, you're right. By lighter or heavier, I mean the ends of the desired value, that some patients stood at around 55 and some stood around 40, 45. Okay. So that's what I mean by heavier or lighter manner. But our measurements show that all patients were anesthetized in a correct way during the measurement, of course.
Mm-hmm. And this is reassuring because the treatment value was 50, yeah? It was just in the middle of the of the end value. Okay, colleague.
That's one question, but very nice English. Thank you. And my question is, because I know about the adults, I know the aware and unaware study was run among the adults that had a TIVA and that showed different results. I don't know about the kids. Would you tell me what complication I can expect when the child is too deeply anesthetized? Is about the hemodynamic things, or is about the length of stay in theater?
It's kind of hard to say for me because all our patients were right in the middle, so where we wanted them to be.
The literature.
But from the literature, when patient is anesthetized too deeply, there will be complications when it comes to waking up. There will be harder waking up of a patient. And I think that complications in general are really similar to adults, to be honest. When it comes to hemodynamic parameters, I would have to read on about it a little more, and I would get back to you with that.
Thank you.
Thank you very much for your valuable comments. Thank you for your work. And now it's time to move on to the next presentation, which is called Diagnostic Accuracy of Presepsin in Predicting the Risk of Death in Patients with Sepsis by Magdalena Kwiatkowska, Katarzyna Marczyk, Sebastian Maślanka, and Jolanta Mika.
So good morning. My name is Magdalena Kwiatkowska, and I have pleasure to present our original research, which is called Diagnostic Accuracy of Presepsin in Predicting the Risk of Death in Patients with Sepsis. Distinguish sepsis from non-infectious organ failure in early stages of treatment is challenging. Unjustified broad-spectrum antibiotic use promotes resistance, and delay in antibiotic therapy can increase mortality. So the ideal biomarker should aid in timely therapeutic decision-making for sepsis. Presepsin is promising biomarker with potential specificity for bacterial infection. It shows promise in identifying patients who requires prompt initiation of antibiotic therapy. In healthy young volunteers, presepsin levels remained below 200 pg/ml. Study have suggest a cutoff point of 600 pg/ml as a threshold for indicating bacterial infection. The aim of our study was to assess the diagnostic accuracy of presepsin in predicting the risk of death and positive microbiological test in patients suspected with sepsis. Our study group consists of 86 patients admitted with suspected sepsis according to sepsis criteria. Laboratory and microbiological tests were conducted. The patients had inflammatory markers measured, including presepsin, CRP, PCT, and IL-6. Two endpoints were defined. The first was death before discharge from the ICU, and the second includes at least one positive result from blood, urine, tracheal aspirate, or BAL. So now look at our results. Out of 86 ICU admitted patients suspected with sepsis, 42 had positive MBT results, while 44 had negative results. The study assessed organ failure scores for ICU patients, including Apache, SOFA, and SAP scores. Patients who died had higher median values of the prognostic scores compared to those who survived. Among the 86 patients, 30 died, and there were no statistically significant differences among the markers in predicting mortality before ICU discharge. All markers demonstrated statistical significance in predicting positive MBT result. In patients with positive results, the inflammatory marker values were significantly higher, with a p-value lower than 0.001 for all markers. As you can see, the ROC curve for presepsin in predicting positive MBT results showed an area under curve of 0.71 with a p-value lower than 0.001, indicating its statistical significance in acutely predicting positive results in septic patients. The ROC curve for presepsin predicting mortality before ICU discharge showed no statistical significance, indicating that presepsin didn't predict mortality before hospital discharge. In conclusion, I'd like to say that presepsin upon ICU admission didn't predict mortality risk. It showed predictive value for positive microbiological testing, and it can be valuable for diagnosing and guiding patients with septic organ failures. Thank you for your attention, and I hope you find it interesting.
Thank you very much for presenting your work. So now it's time to start the discussion based on your presentation.
It was quite interesting, and my question is about the gray area. What should I do if my presepsin level is 300?
It's a tricky question because it depends. We should make we should make decision depend of clinical state of patient.
Okay, I'm quite surprised about the results in terms of mortality, that higher rates of anti-inflammatory factors didn't well corresponded with the mortality rate. And you are quite lucky that you could assess such a sophisticated factors as the perception. And actually, that's it. Nice job, guys. Thank you.
Thank you.
So thank you very much for presenting your work once more. And now it's time to welcome Jan Herzyk and Dawid Wilczek presenting the work titled Hematologic System Dysregulation in Sepsis Patients with Anemia, a retrospective cohort study.
I hope that the last is the best, and I believe that. So, good morning, everyone. My name is Jan Herzyk, and today I would like to talk with you about some hematologic system dysregulation in sepsis patients with anemia. At the beginning, I would like to remind the definition of anemia according to the Sepsis Surviving Campaign. Sepsis is defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. And the septic shock is a specific subtype of sepsis with some changes in circulatory, cellular, and metabolic disturbances. Both sepsis and septic shock can increase the mortality up to the 30%. Sepsis can affect not only the white blood cells, but also red blood cells, platelets, and parameters describing the coagulation system. Septic dysregulation includes both quantitative and qualitative changes in red blood cells. So the primary aim of our study was to assess the impact of sepsis on red blood cell indices, platelets, and standard laboratory tests of coagulation in anemic patients on admission to ICU. And the secondary aim was to analyze association of those parameters with presence of sepsis or septic shock, severity of sepsis according to the SOFA classification system, ICU length of stay, and ICU mortality. In face of that, we performed a retrospective cohort study. We analyzed all patients hospitalized between January 2020 and December 2021 in our local 10-bed mixed surgical medical intensive care unit. There were 3 exclusion criteria: no hemoglobin concentration on admission, no anemia on admission, and active bleeding just before the admission. Moreover, we define anemia according to the WHO guidelines as hemoglobin level less than 12 gram per deciliter in women and less than 13 gram per deciliter in men. In this flowchart, we can see that, as I mentioned, the total number of patients admitted in those years to our ICU was 429. We excluded patients without hemoglobin concentration on admission due to the rapid death just after the admission. There were no time to collect the blood. Patients without anemia on admission to the ICU and with active bleeding or red blood cell transfusion before admission. So the total number of patients with anemia on admission was 217. We divided them into the patients with sepsis or septic shock and patients without sepsis or septic shock. What did we find? In some laboratory parameters in sepsis patient and non-sepsis patients, we can notice that there are many parameters statistically significant. RDW, RDWSD, fibrinogen, PT, APTT, and dedimers had bigger values in group of sepsis patients compared with non-sepsis patients. Only platelets had a bigger value in non-sepsis patients compared with sepsis patients. International normalized ratio was the only coagulation test with acceptable sepsis prediction power. The ROC curve for INR in prediction of sepsis is shown here. So we can see that the area under the ROC curve for INR in prediction of sepsis on admission to the ICU, of course, was 0.7 with an optimal cutoff value more than 1.21. Moreover, combination of INR and fibrinogen level with improved sepsis predictive value measured in some scales like SOFA, like APH2 and SAPS2. We found significant differences in PT and INR between survivors and non-survivors. Of course, the PT was prolonged in non-survivors, and of course, INR had a bigger value. The AROC for INR in predicting ICU mortality in septic patients was 0.67 with an optimal cutoff more than 1.37. A combination of INR with a disease severity score improved its predictive power for all those three classification systems: SOFA 0.7, APH2 0.74, and SAPS 0.75. I think that it's not surprising that non-survivors got higher on all three disease severity classification systems. We can see the values for non-survivors here and survivors here, of course, with a value. We found positive correlation between PT, INR, D-dimers, and TT with correlation of SOFA score. And there was negative correlation between platelets and SOFA score. Only platelets were positively correlated with ICU length of stay. We did not find any other parameters correlated to ICU length of stay, but we have to underline that this correlation is, according to the Guildford classification system, weak. So, in conclusion, sepsis significantly affects RDW, platelets, and most standard coagulation parameters. Moreover, increased INR more than 1.21 can be used for a sepsis screening, whereas combination of INR with severity of disease may predict short-term mortality in sepsis patients. Thank you for your attention, and now I am really honored to answer any questions.
Thank you very much for your presentation. So now we will begin the discussion.
My question is about the RDW. Would you open this description somehow? How should I assess my patient according to this parameter? If I'm admitting patient with sepsis, his inflammatory factors are raised, and how should I assess my patient according to RDW?
The RDW can be bigger in sepsis patients compared with non-sepsis patients.
What is the cutoff value then? When should I be afraid about my patient looking at this parameter?
That's a good question, but we don't know the answer. Okay. We don't remember the value.
Okay. My question is about the HB level then. Should I be aiming the personalized level of HB for particular patient? Should I be looking at some extra parameters like saturation of mixed blood or mixed venous blood or lactate level, how should I assess proper HB level for my patient?
We believe that the restrictive indications for the RBC transfusion are more preferred in these patients. So we believe that the acceptable level of hemoglobin should be considered just to the clinical situation, and we believe that the cutoffs prepared by WHO are enough, but of course, if we have a patient with septic shock, we should consider the issue of hypoxia, and we should look at these parameters during the hospitalization, and just focus on the good blood management and the reducing the effect of hypoxia on our patient.
Are there any ranges for HB, or as you've mentioned, it should be strictly personalized to the patient?
Just in case of RBC transfusion, for example, we should correlate the suitable level of HB just to the clinical situation. For example, patient with dyspnea should have HB level higher than 70 grams per liter. And for example, if patient has acute cerebral ischemia, the Association for Advancement of Blood and Biotherapies suggests that the level should be higher than 80 grams per liter just to the RBC transfusion. So we believe that that's the critical level of HB. And of course, patients should have the most appropriate just to the guidelines of WHO, but sometimes it's very difficult to manage it.
May I add something? There are some studies in which we can see that the restrictive strategy of transfusion decreased the total mortality compared with liberal transfusion triggers like hemoglobin above 9 grams per deciliter. So the lower level had a better mortality. So maybe not a better mortality, but the mortality rate was lower compared with those groups.
Thank you for your answer. Nice job, guys. Thank you.
Thank you very much for the discussion. Thank you for your work. Now all the submitted papers have been presented. We congratulate all of the presenting authors and participants of the session of anesthesiology, emergency medicine, and intensive care. At this point, I would like to ask the president of the jury, Docent Piotr Czempik, for a few words to sum up the session. You can come here. It would be very nice.
Should I speak in English? In Polish? Okay, in front of the camera. So thank you again for coming here. With some of you, we see you each year, every year. I mean, and for me, it's an opportunity to learn about the topics you decided to research. And it's nice to have this feedback on what topic you are working on. I would like to thank all the speakers, obviously, for presenting. I would like to thank the jury for suggestions, for your comments, and for the review of the work. And I think these conferences have two purposes. First of all, I hope you get some feedback on your research, I hope the remarks that we are making, they will be beneficial to you in later stages. Perhaps on the when you start preparing your manuscripts, and also this is important because you present. You interact with the jury. You publicly present the work that you've done, and you will be doing this all your life if you go in this direction. Yes. So I hope each year, with every year, next year, you will be more proficient in this. Some of you are very proficient. Some of you need some additional experience, but it's good. Yeah. It's important that you don't stress out. Yes, you shouldn't be stressing out. You shouldn't be stressing out at looking at us, the jury. Yes. So I would like to conclude this session. Thank you very much for coming here. Thank you for your work, and hope there will be more abstracts next year. And I thank the organizers of the conference. You are working hard, and I know that the website is great, I think, and the fact that we can see it again on YouTube, it's great. Thank you for that, and I declare the session. I declare the end of the session. Thank you.
Thank you very much for such nice words. We truly appreciate your valuable comments, accurate observations, and the work on presentation assessment. We would like to cordially invite you all to the decoration and closing ceremony of SIMC 2023 conference, which will be held in A3 Hall on the 19th of May at 4:15 p.m. On behalf of the Student Scientific Association, I would like to thank you all for participation in this session. And now I'd like to remind you that this day you can participate in a variety of workshops in CDSM halls, like, for example, microbiome 1, elderly simulator, body composition analysis, versatile physiotherapy, hand masks, and also the art of writing a scientific paper, which will be held this workshop in Szaflarski Hall by our special guest. And if you are hungry, for instance, so we invite you to lunch, but at 1 p.m. And I think you should also remember that on our Instagram account, there is a small competition for you. So if you are interested, for example, in pharmacology, I think that's something for you. So thank you very much once more, and have a good day.